This is an educational module on irritable bowel syndrome, also known as IBS, presented by myself, Melissa Moreland Carl. At the end of this presentation, you should have an understanding of what irritable bowel syndrome is and the key indicators for the diagnosis of IBS. Have an understanding of what factors contribute to the development of IBS using integrative and functional medical nutrition therapies Niblet's model. Review 3 conventional and 3 functional tests that are used to diagnose IBS. Have an understanding of how these tests together are helpful in understanding a patient's current health status with this condition. I will present a nutritional care plan with 5 specific nutrition-related recommendations and 3 specific lifestyle-related recommendations. I will discuss how I plan to monitor the patient with IBS and their ongoing health outcome. Last, I will discuss gaps in research for patients with the diagnosis of IBS. Gastrointestinal function and nutrition are a symbiotic process that is linked to health outcomes. Many digestive diseases result in impaired digestion and absorption of nutrients, creating a cascading effect on other systems of the body and overall function. In the U.S. alone, digestive diseases account for nearly $142 billion in healthcare costs annually and affect upward of 60 to 70 million individuals. Food-mediated diseases can start at birth from the delivery method and the feeding methods of an infant. Gastrointestinal conditions and diseases can be triggered by multiple influences, including antibiotic therapies, stress, and other disruptions to the gut's microbial population. Gastrointestinal diseases can have 3 primary origins: organic or structural disease, motility disorders, and functional disorders. Organic or structural disease, this is diagnosed by pathology of GI tissue and or evaluation of structure. Examples of this type of disease would be like colon polyps or ulcers. Motility disorders are abnormal vesicular muscle activity that cause dysregulated peristalsis. This can be diagnosed with gastric emptying studies and whole gut transient scintigraphy. Examples of this type of disorder are gastroparesis and colonic inertia. Functional disorders are the most common GI disorders. The etiology of functional disorders are varied. The difference with functional disorders is they are subjectively reported by the patient. Examples of this type of disorder are dyspepsia and irritable bowel syndrome. Irritable bowel is a functional disorder of the GI system. It affects between 7% and 20% of the population globally. The symptoms of IBS include cramping, abdominal distension, bloating, changes in bowel habit, exaggerated gastrocolic response, vesicular hypersensitivity, and pain. These symptoms often wax and wane. Patients that seek medical interventions often report symptoms with high levels of anxiety that are affecting their daily lives. Other etiological factors may drive the IBS phenotype, including celiac disease, non-celiac gluten sensitivity, food intolerance, and small intestinal bacterial overgrowth. The diagnosis of IBS should be made on 4 key features: clinical history, physical examination, laboratory tests, and when indicated, colonoscopy. The Irritable Bowel Syndrome Severity Scoring System and the Irritable Bowel Syndrome Quality of Life Questionnaire are validated assessment tools that may be useful in the evaluation of the symptoms. The diagnosis criteria for IBS subtypes are evaluating bowel habits based on stool forms on days with at least 1 abnormal bowel movement. The Bristol Stool Form Scale is used to accurately establish stool consistency. There are 3 subtypes of IBS. IBS with prominent constipation, more than 1/4 of bowel movements are Bristol stool type 1 or 2. Patients report abnormal bowel movements, usually constipation. IBS with predominant diarrhea, more than 1/4 of the bowel movements with Bristol stools type 6 and 7. And then IBS with mixed bowel habits, alternating between 1/4 of the stools alternating from type 1 and type 2 to type 6 and 7, or they can have both of these. The Niblet's assessment can identify factors that can contribute to IBS. The N in Niblet stands for nutrition deficiencies and insufficiencies. It's important to understand the nutritional intake for patients with IBS due to the bowel patterns they may experience. Patients may be nutritionally deficient, including a low FODMAP diet where poorly absorbed and rapidly fermentable carbohydrates are avoided has been an effective treatment and nutritional therapy. I stands for inflammation and immunity. This is a key assessment for IBS. Factors important to the development of IBS include alterations in the gut microbiome, intestinal permeability, gut immune function, motility, visceral sensation, brain-gut interactions, and psychological status. To explain the brain-gut interactions, there must be an understanding of the enteric nervous system. The enteric nervous system and central nervous system communicate along vagal and autonomic pathways to modulate many GI functions. Several crucial neurotransmitters are synthesized locally in the GI tract, including serotonin. Serotonin influences small intestinal motility. The administration of serotonin agonists and antagonists alter intestinal function. Assessment of stool type using the Bristol stool type assessment and pooled prevalence of a positive lactulose hydrogen breath test are useful in diagnosing IBS. B stands for biochemical individuality and a genetic epigenetic influence on chronic disease. Genetic risks in IBS span from complex polygenic conditions with combinations of common variants to cases with rare single gene variants, each contributing a small risk factor. Therefore, assessing family members for IBS may be useful in the treatment of the patient. L is lifestyle assessment. In clinical trials, patients with IBS have exhibited significantly higher levels of anxiety and depression. Common clinical psychological manifestations in patients presenting with IBS include anxiety, depression, and somatization disorders. They are more likely to have been physically or sexually abused in childhood. These factors can influence seeking care for IBS. Psychiatric disturbances and abuse history can influence the severity of the symptoms. Assessment of the patient's anxiety and depression and understanding their past and current history of abuse is essential. Understanding the patient's social support can influence their ability to manage IBS. Other critical assessments are understanding how IBS is affecting their work schedule. It's also important to ask about the use of drugs and alcohol to understand how they are coping with IBS. E is the assessment of energy. Assessing the amino acid L-glutamine serotonin precursors in the 5-hydroxytryptophan may help in understanding the lack of energy patients are receiving from their nutritional sources. T is the assessment of toxic load. For patients with IBS, the patient may be eating a diet that is toxic to their GI system. Dietary considerations may include avoiding large meals, elimination or reduction of lactose, sorbitol, mannitol, xylitol, fructose, high corn syrup, and honey. S is the last assessment of the NIBLS assessment. The S assesses the patient's stress. The stress for a patient with IBS may already be evaluated in the lifestyle assessment. However, it must be evaluated for how the body is maintaining the microbial gut-brain axis. When conventional testing versus functional medicine testing is looked at, it's agreed that there's no single test that determines and diagnoses a person with IBS. Conventional medicine states, again, that there's no specific or single diagnosis for irritable bowel syndrome, but tests to exclude organic disease such as colon cancer, inflammatory bowel disease, or celiac disease are recommended according to guidelines for screening for colon cancer or the presence of alarm features such as weight loss or rectal bleeding. A history of rectal bleeding, weight loss, nocturnal diarrhea, symptoms suggestive of a somatoform or psychological disorders such as anxiety or depression, and screening blood tests such as hemoglobin and C-reactive protein enhance the diagnostic performance of symptom-based criteria for IBS. From a functional testing standpoint, the initial approach to IBS remains one of excluding more serious causes of persistent intestinal symptoms. To begin with, it's important to rule out IBD, celiac or gluten sensitivity, and lactose intolerance, all of which could require a different treatment approach than IBS. Tests for infectious agents should include a screen for typical bacteria pathogens like Clostridium, protozoa, and then things like Candida as well, yeast in Canada. For patients with recurrent bloating, especially when it occurs soon after eating, a hydrogen methane breath test can be helpful for diagnosing SIBO, a problem that is either comorbid with IBS or for some individuals the primary cause of IBS. Fecal calcoprotein or lactoferrin are excellent biomarkers for differentiating between IBS and IBD, infectious enteritis, or cancer. Although both Both tests have utility by themselves. Combining the two provides more sensitivity and specificity. Patients with long-term symptoms, especially if bleeding is present or if fecal calciprotein levels are elevated, should undergo a colonoscopy to rule out the presence of ulcerative or cancerous lesions. Symptomatic treatment, if no alternative diagnoses appear to be relevant and a patient is considered, then the patient is considered to have IBS. That's where integrative and mainstream medicine began to diverge in their approach to patient management. Symptom control to ease patients' discomfort and improve their daily lives is certainly desirable, but does not solve the underlying problem and should not be considered the beginning and end of treatment. Conventional symptomatic treatment focuses mainly on medications such as loperamide to alleviate diarrhea, polyethylene glycol powder or Marilax for constipation, and they may do antispasmodics for abdominal pain and cramps, and if warranted, tricyclic and other antidepressants for antioxylytics. One of the most effective and extensive studies that have been done is herbal remedies for IBS related to pain and spasms is actually peppermint oil, and that's usually dosed at 1 to 2 capsules 3 times a day. In both conventional and functional diagnosis of IBS, it's recognized that it is difficult to diagnose this syndrome with symptoms. The conventional approach is a good start to identifying IBS and ruling out other diseases and syndromes. The functional approach is the second layer of a better understanding of this syndrome. Using alternative testing to better identify IBS and rule out other similar issues that may be occurring. After identifying irritable bowel syndrome and giving a patient this diagnosis, creating a care plan with them to help alleviate their symptoms would be the next step. It is suggested in research to use the 4R approach. Remove is the first R. Remove potential sources of non-noxious stimuli that may be contributing to the person's symptoms. This includes 2 main steps. One is looking for pathogens that can be treated, such as harmful bacteria and parasites. And 2 is to remove by restricting rapidly fermentable short-chain carbohydrates. Some people again do not absorb these carbohydrates well, especially in the small intestine, so they are fermented by bacteria, leading to distension of the bowel wall and irritation of the gut. And using a low FOD MAP diet for 6 to 8 weeks may lead to an improvement in these symptoms. Unfortunately, although it's generally well tolerated, rifaximin is extremely expensive. It's a medication that can help with this disease. It's like over $700 for a course of treatment, so that puts a major limitation on its use. In addition, some researchers question the wisdom of using a broad-spectrum antibiotic to correct a condition in which there may already be a decrease in microbial richness and diversity. The risk of allergic reactions or other side effects from the antibiotics should also be considered. Without a clear and powerful strategy to restore that diversity, it's possible that the SIBO or dysbiosis could rebound after the person stops taking the drugs. An alternative to antibiotic therapy is to use herbal antimicrobials to eliminate suspected bacterial overgrowth or imbalances. Typical options include berberine, garlic, and oil of oregano. Their advantage is that they appear to suppress pathogenic strains without wiping out the healthy flora. This is based on observation of people who have taken berberine or garlic for long periods of time without developing evidence of a disrupted microbiome. Repair. If dysbiosis is present with disruptions of the intestinal environment, then damage to the gut mucosa is likely to have occurred. The nutrient with the strongest research base to support its capabilities to repair the gut wall is L-glutamine. It is a primary fuel for enterocytes and can stimulate healthy enterocyte proliferation. Therapeutic administration of L-glutamine has been shown in animal studies to promote epithelial recovery in the injury of small intestine. Typically that would be dosed at 3 to 15 milligrams a day. Replaces digestive enzymes can be derived from pancreatin, fungi, or fruits such as pineapple or papaya. Pancreatin, which contains a combination of amylase, lipase, and protease, is very potent and helps digest a wide range of foods. It's most effective in the high pH of the small intestine. The final R is reinoculate. This involves giving prebiotics, fibers such as inulin, FOS, and larch, and their probiotics to deliver good bacteria to the gut, along with supporting the growth of existing good bacteria. So food journaling is essential to understanding the patient's food intake and related to their symptoms. Due to the psychological component of IBS, lifestyle changes are necessary in the treatment course. The brain-gut interactions are increasingly recognized in the pathogenesis in almost half of the IBS patients with comorbid psychiatric disorders. The patient's stress and mental well-being should be evaluated. Possible referral to therapists for other treatments may be needed. Other alternative therapies that may be suggested based on the individual's needs may include meditation, yoga, hypnosis, acupuncture, and biofeedback. We know IBS is difficult to diagnose and can be harmful to the patient's everyday living in both social and mental aspects. With this patient, I would plan to monitor this patient weekly for 6 to 8 weeks. I would recommend alternative therapies and refer to other practitioners as needed based on the individual presenting with IBS. At the 6-week follow-up, I would do a full reassessment of the patient's current symptoms and possibly lab work if needed. If improvement in symptoms, I would follow up in 2 weeks for 3 times and then monthly for 3 months. If there was not an improvement in the symptoms, I would reevaluate the plan with the patient and ensure compliance. I would encourage the patient and support the patient with tools for success. I may suggest family support, meal planning strategies, and again, alternative therapies to complement the nutritional therapies. Due to the nature of IBS and how symptoms can be varying without a definitive diagnosis, I would consider alternative diagnosis as well. Irritable bowel research in the conventional and functional medicine are similar in approach. It's first to understand the patient's symptoms. This approach alone can be difficult. As many patients become accustomed to familiar patterns of digestion and elimination, skewing the perspective and subjective experience. One of the gaps in research is an incomplete understanding of the gut-brain axis and the microbiome of the gut. Further research may bring new evidence for treatment of IBS. Also, there's limited information on how genetics may affect IBS. It's certainly an aspect of the disease that warrants further investigation. In conclusion, I hope you have a better understanding of irritable bowel syndrome, the assessment tools used to diagnose IBS, the treatment using the 4R mnemonics, and an understanding of treatment. Thank you.